cervical spine allows for both support of the head and for movements of the head. With evidence of injury above the clavicles or in any comatose patient, the examiner must rule out a cervical spine injury before moving the patient. In the older population, degenerative cervical disc disease and degenerative arthritis of the cervical spine prompt many patients to seek medical attention. Because the cervical spine is intimately related to the peripheral nerves of the upper extremities, symptoms may be referred to the upper extremity or chest wall, and a detailed neurological examination of the upper extremities is an integral part of the examination of the cervical spine. Inspection. Note the posture and attitude of the head and neck region. Normally the patient holds his head erect and the neck moves freely. Any splinting or tilting of the neck may signify pathology. In contrast to the normal patient, note how this patient with ankylosing spondylitis lacks freedom of motion and must turn his body when attempting to turn his neck. The patient should be undressed to the waist and the neck region closely inspected for any swelling, scars, or other abnormalities. Note the symmetry when looking from the front and from the back. Note also from the side the normal lordosis of the cervical spine. Palpation. Cartilaginous and bony landmarks. With the patient lying supine, the neck muscles are relaxed, and the cartilaginous and bony landmarks anteriorly can be more easily identified. Thyroid cartilage. The superior aspect of the thyroid cartilage is usually visible and is commonly referred to as the Adam's apple. The superior margin of the thyroid cartilage lies anterior to C4 and the inferior margin at the level of C5. Hyoid bone. Superior to the thyroid cartilage, localize the hyoid bone between the thumb and the index finger. Note the mobility of the hyoid bone and also the thyroid cartilage when the patient swallows. The hyoid bone lies at the level of C3. First cricoid ring. The first cricoid ring of the trachea can be located immediately inferior to the thyroid cartilage and lies anterior to the body of C6. The ability to identify these anterior landmarks is extremely important in performing tracheostomies or cricothyroidotomies. Spinous processes. In the midline posteriorly, palpate the spinous processes from C2 to T1. Note any tenderness to palpation or any shift of a spinous process away from the midline. Inion. Superiorly in the midline of the occiput, localize the prominence or inion, commonly referred to as the bump of knowledge. Palpation. Soft tissues. Sternocleidomastoid muscle. This muscle is easily identified by asking the patient to turn the head to the opposite side against the resistance of the examiner's hand. The sternocleidomastoid muscle stands out near its attachment at the sternoclavicular joint region and can be followed upwards to its attachment into the mastoid process behind the ear. Examine each muscle in turn, noting any localized swelling or areas of tenderness. Lymph nodes. Carefully palpate along the anterior medial border of the sternocleidomastoid muscle to detect any enlargement of lymph nodes in this region. Also palpate the region of the supraclavicular fossa bilaterally, noting any swelling or enlargement of lymph nodes in that region which under normal circumstances are not palpable. Carotid artery. Anterior to the mid-portion of the sternocleidomastoid muscle, localize the carotid artery. Palpate each pulse separately, noting the volume. The carotid artery should be auscultated to detect the presence of any bruise. Trapezius muscle. With the patient sitting and the examiner standing behind the patient, identify the lateral borders of the trapezius muscle. They can be easily located by asking the patient to shrug the shoulders while applying resistance over the acromions bilaterally. Palpate the trapezius muscle inferiorly to its attachment on the clavicle, acromion, and spine of the scapula. Follow the trapezius muscle superiorly to its attachment at the posterior aspect of the occiput. Lymph nodes. Under pathological conditions, lymph nodes may be palpable along the anterolateral border of the trapezius muscle, and this region should be carefully palpated. Greater occipital nerves. Identify the inion or posterior prominence of the occiput in the midline and probe laterally along the base of the skull. Tenderness elicited in this region may suggest inflammation of the greater occipital nerves. Range of motion. Active. The cervical spine has a wide range of motion consisting of basically flexion, extension, rotation, and lateral bending. Combinations of these ranges impart a wide versatility of motion to the cervical spine. The majority of flexion extension takes place at the occiput C1 level, and the majority of rotation takes place around the odontoid at the C1-2 or atlas axis level. This can easily be recalled by remembering that saying yes is a higher function than saying no. Flexion. The patient is instructed to bend his head forward and should be able to touch the chin to the anterior chest wall. Extension. The patient is instructed to bend his neck backwards, as in looking up at the ceiling. Normally the patient should be able to look straight up at the ceiling, and thus the face is essentially parallel to the floor. Flexion and extension are best observed from the side, and as well as the range of motion, the smoothness or rhythm of motion should be noted by the examiner. Rotation. Instruct the patient to turn the head to the side, and under normal circumstances, the chin should almost be in line with the shoulder. Test rotation to one side from the neutral position, then to the other side. Lateral bending. While observing from the front, instruct the patient to tilt the head to the side and attempt to touch the ear to the shoulder. Observe the range of tilt from the midline, and do not be fooled by a shoulder shrug that the patient will frequently do in order to approximate the shoulder to the ear. Range of motion. Passive. Before attempting passive range of motion, a brief explanation of what you are going to do will allow the patient to relax fully and cooperate with the examiner. Caution. 2 points of caution must be observed by the examiner when testing passive range of motion. In any case of trauma where cervical spine instability is potentially present, passive range of motion should not be performed. Never attempt to force the cervical spine when testing passive range of motion. If motion is restricted, there must be a reason, and an attempt to passively exceed that range may be hazardous. Flexion. Standing behind the patient, support the head with both hands and passively flex the neck anteriorly and return to the neutral position. Extension. Passively extend the neck, and normally the patient will be able to look directly up at the ceiling. Rotation. From the neutral position, rotate the head to one side and then the other, comparing the degree of rotation to each side. Lateral bending. Bend the head laterally towards one shoulder and then to the other, noting the degree of lateral bend on each side. Neurological examination. The neurological examination related to the cervical spine and the upper extremities includes a detailed sensory, motor, and reflex examination. Patient relaxation and cooperation is mandatory, and a careful explanation of what is happening will greatly assist in this regard. Sensory examination. The following points must be noted on sensory examination. During sensory examination, the examiner should explain to the patient precisely what is going to take place, and the patient should have the eyes closed. Each sensory dermatome must be individually examined and compared to the corresponding dermatome on the opposite side. The examiner must test the following sensory modalities: pinprick, blunt or dull touch, light touch, temperature, warm and cold, two-point discrimination, which is especially important in the hand region, proprioception, and vibration sense. Note any deficiencies of sensory examination on a diagrammatic chart depicting the exact localization and area involved, so that comparison with subsequent examinations can be readily made. Motor examination. The examiner is reminded that the following points are essential components of a proper examination of the motor system. Examine each specific muscle or group of muscles when the individual muscle function cannot be isolated. Palpate the individual muscle or tendon if possible. Record the strength of the muscle or muscle groups being tested on the 0 to 5 rating scale. Always compare the strength of a muscle or muscle group to its counterpart on the opposite side. In this program, the muscles related to the cervical spine, the shoulder, and the elbow region will be tested. Motor testing for the hand